think it's important to choose your cases wisely. You want to make sure that you're tackling patients that have a large, relatively straight radial artery with a very palpable, very strongly palpable radial pulse. I would also try to stay away from super complex cases. Maybe you don't want to start with a rotational atherectomy or a bifurcation or an unprotected left main type of case. I think you want to make sure that your chances for success are high for the first several cases. If I've gotten access through the wrist, so if my sheath is in and I can't get to the central aorta, I want to really understand why. Is it spasm? Is it a congenital anomaly? Is it a atherosclerotic lesion? Or is it simply tortuosity? So I think the best way to define the challenge is by doing a angiogram through the sheath.
Where you may encounter more problems is in spasm in the forearm, in the radial, or tortuosity in the subclavian and as you go down into the ascending aorta. So there are tortuosity that can be encountered there, and there are also cases where the subclavian origin may be very more distal in the aorta, and then the catheters will have a tendency to go down the descending aorta instead of the ascending aorta, which will cause some difficulty with the torque and access of both ostia, and so those are certain difficulties.
If it's a radial artery loop and you're a relatively novice operator, then I would say probably move to the femoral approach. As time goes on, you might want to tackle some of the tougher cases, but for congenital anatomic variations, you might want to steer away from those cases to start with.
Atherosclerotic disease, loops, tortuosity, both in the radial, both in the brachial, and the subclavian. The treatment is one thing, the 014 wire. The 014 wire will get you right into the ascending aorta. Once you have your 014 wire in the ascending aorta, you can do usually your regular catheters, the 014 wire, and it doesn't have to be an extra stiff. People always ask, oh, should it be an extra? No, just be your standard middleweight 014 wire. You're in the ascending aorta, and for the most part, you will be able to take your diagnostic catheter right up, and it'll straighten it enough. If that doesn't work, and there's some resistance because there's some calcification or there's a lesion, you take a multipurpose. The multipurpose is much straighter. It almost always goes up. And at that point, you can either do the entire diagnostic with the multipurpose, or you switch over to your J-wire, which is a more supportive wire, and then you can deliver everything.
Generally speaking, the radial artery is somewhat big and goes up to about the elbow where it joins the brachial artery. So the ulnar and the radial originate from around the elbow, and then they both go down. But there are cases when the radial artery is very small and the ulnar is big, or the reverse is also possible. And there are cases where the bifurcation for the radial is more proximal towards the upper arm. And there are cases where there are loops, and we've seen very big loops in the radial artery, which also can be a problem that can be overcome quite easily with hydrophilic wires as you go up.
If it's spasm, certainly you're going to give appropriate pharmacologic cocktails and try to relieve the spasm. Sometimes downsizing from a 5 or 6 to a 4 French catheter can help in that situation. If it's significant tortuosity, using either a hydrophilic coated wire or a more steerable wire such as a Versacor or woolly wire could be helpful.
Spasm is the most common thing that you will encounter. The obvious answer are antispasmodics, nitroglycerin, verapamil, cardine. They work. Hydrophilic sheets significantly reduce the amount of spasm. Just imagine how smooth the transition is. But the thing that nobody talks about, that really, really works for spasm is time. And now, in the cath lab, 10 minutes is like 10 hours, okay? But really, spasm is cured by time. So even if you're using the right equipment, the patient's having spasm, you give all of your antispasmodics, they're still having spasm, sedate the patient, make sure they're comfortable. That helps. But sometimes you just need a little time. Step back, walk away, let the patient relax, let the artery come out of spasm, and you will be able to proceed with the case.
I think it would be helpful to present to those individuals that are a little bit reticent to proceed with transradial catheterization that there is some good data out there to support the benefits of transradial catheterization, both in terms of reduced bleeding complication and better patient outcomes, as well as patient satisfaction, as well as some economies in terms of nursing time and financial concerns.
Get your staff very comfortable with this. If you spend as much time getting yourself comfortable as you do with your staff, it's going to work out great.
Perhaps even the best way to sway anybody that's a little bit reticent to proceed with radial catheterization is to let the patients decide. If you leave it up to the patients can drive the bus. And I can assure you that that the majority of patients will prefer to have the procedure done through the wrist as compared to the groin for obvious reasons.